and sharing her knowledge with healthcare providers like yourselves. So again, thank you guys for jumping on the call. With that, Kathy, I am going to turn it over to you.
Excellent, Mark. Can you hear
Two
me?
things real quick, Mark. This is Kim before we jump off. Kathy, sorry to interrupt. Just one more reminder, everyone. Could everyone other than Kathy, please make sure you're on mute. Got a lot of background noise and a lot of folks not on mute. And also want to let you know, I will be recording the call just for reference. So again, just everybody, if you could slip on mute and enjoy being recorded. Thanks, Kathy.
Thanks, Kim. I appreciate it. Mark, Scott, thank you so much. Dr. Anderson, if you are on, thank you for helping this to happen. Like Mark said, I reside in sunny Florida, Palm Beach County. Please forgive any background noise, but the county has decided to rip up my streets, and it seems to be happening today again. So I'll do my best to talk loud. Can everybody hear me okay? Mark, Kim?
Yeah, we still have some folks that are not muted.
Yeah, still need Sandra Dietrich. We can have background noise coming from you. Can everyone please take a moment, find your mute buttons?
It says it's muted.
Let me see if I can mute you.
You might be able to mute everyone.
Oh, I'm afraid I'll mute you too. You're right, Sandra. It says that, okay, so let me go through here. I've got a handful. So I'm going to try to just mute as we go.
All right. Do you want me to continue?
Yes, please.
Okay, excellent.
Sounds good now.
So as Mark had shared, this is a two-part series. So today we're going to be talking about the treatment of periodontal disease. And there's been a lot of changes, but the change that I believe that isn't happening quick enough is that our patients do not recognize us as part of medicine. All too often, we will hear our patients say, oh, I just want my cleaning. Why do you have to do that? And if it doesn't hurt, how could it possibly be? And updating medical histories, why do you need to know that? It's only about my mouth. It's not the rest of my body. So I want us all to make a commitment as dental healthcare professionals and medical professionals to help to educate our patients that we are an integral part of medicine. And as I go through these slides, you'll see exactly why. But before I go through them, I wanted to share a video with you that really encompasses why we are an important part of medicine. And we are the only people that deal with some of these #1 chronic diseases, which are dental diseases. And I'm going to pray everything works. And of course, it always works when I try, test it, and it doesn't work afterwards. There we go.
Hey, Kathy, we're not hearing. I think it's just music, but.
Okay, it happens every time we stall, and then I have to go on and off and share and stuff. Do you want me to go back and reshare?
No, that's okay, because I think it's just music, right?
It's just music, yes.
Okay.
So let me just finish. Although the music does a crescendo, so it really gives extra effect. And this is where I want to stop for a moment, because I want you all to realize that what you do on a daily basis is even more than removing calculus, controlling inflammation. It's about saving lives. It's about getting those medical histories, identifying if there's any other issues that are connected to the oral cavity, sharing and educating your patients so they understand how they can take care of themselves. So the next time any of you feel that you're just doing a cleaning, or if the doctors get frustrated because patients aren't following through with treatment plans, try to remember you are so much a part of the medical team. And yes. Can you hear me?
No.
Yeah, Kathy, we've got you loud and clear.
Oh, okay. I'm sorry. I'd heard somebody say something. So just, remember we are part of that medical team, and please find a way to educate your patients and let them understand that. And that'll come through a little bit more in the next presentation. So we do know that dental decay is the #1 chronic childhood disease. We've heard about oral cancer killing 1 person every single hour. And then, of course, we have the prevalence of periodontal disease. A little over 90% of the population have some form of gingivitis. Periodontitis affects about half of the adults that are 30 years and older. And then as we mature, as I'm embarking into my 60s, about 70% of the population is affected with periodontal disease. But what is very, very interesting is that the World Health Organization studies about 365 diseases to identify what are the global burden diseases in the world. And regrettably, dental decay and periodontal disease are the #1 contributing factor to the global burden of chronic diseases in the world. It's the 6th most prevalent disease of mankind. Again, we are the only ones that treat this disease, and it has increased by 57% from 1990 to 2010. And this is probably due to the structure of the biofilm. Biofilm structure was identified in 2003. I graduated from dental hygiene school about 21 years ago. I was taught that it was a single microorganism caused this disease, that it was not a biofilm structure. But now we know there are about 80% of the pathogens that form biofilm are associated with persistent infections. And I want you to think about the probing depths or the pockets that you're seeing with your patients, even whether it be this morning or later this afternoon or yesterday. In a 5-millimeter probing depth, that's a pocket of 5 millimeters. Some of it could be true attachment loss. Some of it could have part pseudo pocket. There are 10 million bacteria in there. And there are 1 billion bacteria in a 10-millimeter or greater probing depth. And then there are 500 different bacterial strains that are identified within this structure. So this is why we are dealing with a very, very toxic and chronic disease that we're having challenges controlling. It's because of this biofilm structure that we have. And then we have the oral systemic link. Not too sure if anybody remembers when the mouth-body connection happened, but it happened to be in the year 2000 when the American Surgeon General had written the report, Oral Health in America, and had identified that there's an oral systemic link. Since the year 2000, there have been 57 diseases and conditions that have been studied with their connection to periodontitis. And a lot of research has recently come out. I think one of the few good things that happened with COVID is it gave some people time more to start doing studies and research. And also we heard more about inflammatory diseases, inflammatory markers. We need to understand that periodontitis is also an inflammatory disease and affects our patients similar to how other inflammatory diseases affect our patients. So this is why dentistry needs to be treating dental diseases, which are inflammatory diseases, parallel to how medicine treats medical diseases and inflammatory diseases. We've always known that there's a participant is now exiting. We knew that there was an oral systemic connection, but we didn't know the mechanism of action. We didn't know cause and effect. I remember when the oral systemic link first came out, the American Academy of the Cardiology Academy, they were kind of a little upset at dentistry because a lot of us were saying you could have a heart attack. Well, we really didn't know cause and effect. We didn't know how the inflammatory reaction of the periodontal disease actually affected the cardiovascular disease. So this is a study that had come out. This was just released in October of 2020 last year, and it really explains what happens. So once periodontal inflammation happens, there's an overabundance of neutrophils that are circulating. So if you think about it, when you have an active bacterial infection, the immune system wakes up to be able to try to handle this infection. The immune system responds with excessive forces to the secondary infection. So if you have cardiovascular disease, that's your primary infection. Now you add periodontal disease, that's the secondary infection. The body cannot control these infections. So what the body does is it sends out specific enzymes, called cytokines, to destroy the tissue and the organs that are creating this inflammation. That's why it's so important if you have cardiovascular disease, diabetes, other inflammatory diseases, periodontal disease, to control that inflammatory response. Because what happens if you have a primary infection of cardiovascular disease, secondary infection of periodontitis, you will have what they're calling a cytokine storm. Those cytokines do not know whether they're supposed to attack one or the other, so they attack both in full force. So that's where you will have the challenges of the heart additional on top of what's going on with the periodontium. Then there was another connection that was recently done in, also it was released in October of 2020, wanting to find out about the connection between COVID-19 and periodontitis. And we're looking at the respiratory complications. So previously, we've always known that periodontitis was linked to respiratory disease. We knew that our patients had an increased risk for complications and a higher mortality rate in hospitalized patients. My mom was in ICU in the later parts of 2020, and she had been intubated, and they were coming in every few hours, swabbing her mouth with chlorhexidine because they knew that she could have exacerbated some of the periopathogens into her lungs, and they didn't want that to happen. So now we understand that there's a circulation of these specific inflammatory markers called interleukin-6 markers. They're circulating, and those are the respiratory markers. Those are markers that are also released with the inflammatory response from periodontitis. And again, we're having those cytokine storms, which are doing destruction on the respiratory system, and again, on any other tissue that is causing the inflammatory concerns. The World Health Organization is actually looking at using these interleukin-6 antagonists in the critically ill patients to see if it could possibly save some lives. So if they could control the release of these specific interleukin pro-inflammatory respiratory markers that are released during periodontal disease and during COVID, that maybe they could actually help to save lives. So could you imagine if you could control your patient's periodontitis and they have cardiovascular disease, they have diabetes, they could be susceptible to COVID. As we know, it's going all around us. And maybe you could eliminate or lessen those chances of having any other reactions in the body. That's what makes us an integral part of medicine. When we got shut down due to COVID-19 back in March of 2020, I had a personal effect from that. I truly believe that what we did was imperative, and treating our patients' periodontal disease, especially those with other comorbidities, was critical. So I do believe we were a critical part, but others might not have agreed with me. So, but what happened when we shut down, a lot of our patients didn't come back right away. They didn't have their 3-month recares. They didn't have their 6-month recares. Their at-home oral habits changed. A lot of our patients became depressed. The anxiety of what's going on in the world, of this disease, of these virus, was creating havoc on our patients. So now, about a year later, when people are a lot more comfortable coming back, we are seeing a higher prevalence of periodontitis and, of course, other dental diseases that we might not have seen pre-COVID. So again, we have a lot of work to do in being able to help our patients in identifying these diseases and being able to successfully treat them. So chronic inflammation, we know this, we've known it for years. Periodontitis is also a chronic inflammation, a chronic disease of inflammatory. And we know that it weakens the immune system because it constantly is asking the immune system to work.
Is now joining.
So non-surgical periodontal therapy can actually help to reduce those systemic levels of inflammation, reducing those cytokine releases and reducing those cytokine storms. If there's a primary, secondary, or what if your patients have a third condition? What if they're cardiovascular disease and diabetic? They go hand in hand many times. And then you throw periodontitis on top of it. That is an enormous amount for anybody's body to handle. This is a lot of the reason with this new studies of the oral systemic link, why the American Academy of Periodontology changed their classification scheme to really align ourselves, dentistry be more aligned with how medicine categorizes diseases, especially oncology. We know that oncology has stages of disease. We know stage 1 cancer has a higher rate of successful treatment and long-term life than stage 4 of cancer. We also know with the person with stage 1 cancer would have a completely different regimen of treatment than a person that has stage 4 cancer. Now you add in modifiers such as other comorbidities, and we realize that we may need to treat some people differently and not everybody should be treated as the same. I just want to reiterate here that it's important that we still do our periodontal diagnosis. Staging and grading is only a stage of the disease and a grade for successful treatment on it. It is not the diagnosis. The dentists still have to do that diagnosis. I wanted to share this with you. If anybody would like to take a picture, please feel free to do. But I wanted to look at what some of the important factors that staging and grading have identified for us. We need to really hone in on those health histories of our patients. I'm going to talk more about that in the next presentation of how good communication with health histories and risk factors can actually help our patients understand why we are part of medicine and why it's important to treat these diseases. Identifying the disease modifiers such as A1C for our diabetic patients and tobacco users. Many of our patients may not know what their A1C is, and if they're not having regular testing, it might not even be accurate, the one that they do know. But we can ask our patients what their glucogen levels are. Mark had shared with you that I sat on the board of dentistry for a little over 9 years. And what I learned in that is that the boards of dentistry don't set the standards of care. Those standards of care are set by the dental organizations. So the American Academy of Periodontology sets the standard of care in treating periodontal disease, identifying it, and doing the diagnosis. So if they've labeled that diabetics controlled or out of control actually are creating havoc in it and having challenges with treating this disease, that means they've set that standard that we need to understand our diabetic patients by asking them what their glucogen levels are and documenting that in our patients' charts. Again, a great way to make that connection between medical dental. And then look at developing a personalized treatment plan that's based on the exact modifiers that your patients have, their medical history, their risk factors, and of course, their dental history and social history. Not everybody should be treated the same. When I graduated in the year 2000, I treated every sulcus the same. We scaled every single sulcus, used our ultrasonic on every single sulcus, and everything was the same. But we have to look at maybe treating people in different areas a little bit differently than we did in the earlier years of my career. So the changing theory in that treatment is when I graduated, we did what they don't even really teach anymore, was scaling and root planing. And I don't mean that they don't teach the theory of doing periodontal, non-surgical periodontal therapy, but we don't teach glass root surfaces. We don't treat removing the cementum any longer. I used to have my instructors would come by with their 11, 12 Explorers and literally go over a surface at least 7 or 8 times to find out if it was glass root or not. We understand now that we really need to kind of preserve that cementum because it helps with reattachment. Yes, we still need to remove the calculus, but our focus is not so much on removing every single granular bit of calculus. It's so much more about biofilm control. The calculus is an anchor to the biofilm. The calculus does not cause this disease. Very hard for me to have had a grasp of that because I'm still come from the glass root surfaces era. So determining which sites should be treated, we need to start looking at our periodontal depth and attachment levels, of course, because that helps us to understand. But we really need to be looking at other indicators along with that, which is bleeding upon probing and the other modifiers of predisposed factors. Bleeding upon probing is an indication of active disease. So if you have a patient who has active non-surgical therapy and you put them through the therapy and the treatment and they're now on their perio maintenance, if you're doing a perio charting and there's no bleeding upon probing, that means they are in full maintenance phase. If there is bleeding upon probing, they are not in full maintenance phase. They have active sites of infection, which are at risk for releasing the inflammatory responses, the immune response, the cytokine storms, and more attack on the periodontium. So monitoring the health, which includes inflammation of the gingiva, and documenting bleeding upon probing, and then looking at what you're going to do for that patient when they have those specific indicators. Non-surgical treatment, let's look at it. We know, every single hygienist who's on this webinar knows, no matter how good we are, I taught instrumentation for 12 years at my alma mater. And I consider myself a pretty good scaler, but I cannot remove all of that calculus. I cannot remove all of that bacteria that is left behind. It is free-floating bacteria. It goes and hides in crevices near the cemento-enamel junction. It actually can embed into the dentin tubules and go and embed into the epithelial lining of the gingiva. So even if we think we got a lot of that biofilm, a lot of that calculus out, we leave free floating behind. So I want you to think about your patients who have a 5 millimeter or a 6 millimeter probing depth, which is extremely common. And you're doing your wonderful non-surgical therapy. You're using your hand instruments, your ultrasonic instruments. Even if you're using a laser, you're going to be getting, say, without using a laser, you're going to probably get about 90% of that bacteria out, let's just say. Using a laser, you're going to get a lot more of it. But the laser only does it at initial. It doesn't keep doing it for long term. So say you've left 10% of bacteria at the base of that sulcus free floating. Can the patient floss 5 or 6 millimeters sub G at the base of that sulcus? No, they cannot. And the whole treatment of home care is they need to do that mechanical disruption of that bacteria on a daily basis, or at least an every other day basis, in order to disrupt the bacterial growth of those pathogens. So if they cannot mechanically disrupt the free floating that's left behind, or the new colonizers that will colonize within 72 hours and become pathogenic, that'll colonize immediately, but it becomes pathogenic in 72 hours. This is why we have a hard time controlling this disease, because we never can stay ahead of it. So even if you're using your laser, it's phenomenal because you will do bacterial reduction higher than ultrasonics, piezos, and hand. But again, it's only at that initial. 72 hours, if they are not disrupting the growth of that biofilm structure, it will turn pathogenic within that 72-hour period. The area needs about 21 days free of irritants in order to be successful with long epithelium attachment. That is the true goal of periodontal non-surgical therapy, is gaining attachment. A secondary goal is stopping that inflammatory response. and looking at the microorganisms that are actually resistant to scaling and root planing happen to be all of those gram-negative or red complex. And the ones that go into the tissue and hide in the tissue, again, are our gram-negative or red complex bacteria that cause periodontal destruction. So this is why Arestin placed in the sulcus, it's a broad spectrum. It will help any of that free-floating bacteria that was left behind to kill it. It'll also kill the bacteria that recolonizes that sulcus, especially the pathogenic within that 72 hours. And it's bacteriostatic and it's antimicrobial. So it inhibits that protein synthesis. So if you can kill the bacteria within that sulcus, you will be a lot more successful at gaining that long epithelium attachment and having that reduction in probing depths that we need. The American Academy of Periodontology also does support the use of what they call LAAs, and they use it for treatment at initial therapy and then looking at treating at periodontal maintenance. Because again, we want to make sure that any of those active areas, I call them hotspots, when we're doing our periochart and bleeding upon probing, we need to treat that differently than we treated it before it was diseased and infected. So like other bacterial infections, we need to think about antibiotics. What other medical profession would ever treat a bacterial infection without an antibiotic, especially if they could get to the site of the infection? So think about it. If you had a bacterial infection in your eye and you went to your ophthalmologist would cleanse it out, flush it out for you, give you some solutions to flush it out, keep it clean at home, just like we want them to keep the sulcus clean. But they would also give you antibiotic drops because they understand the composition of these pathogens and how the body cannot take care of them themselves. So I want you all to think, if your body or anybody's body could fight these pathogens and control this infection, our patients would never go from gingivitis to periodontitis, would they? And again, that's maybe a healthy patient. Think about the ones that have weakened immune systems, which are many of our patients today. This was a great study that Arestin had done. It was a single double-blind study of 748 patients that were broken into 3 groups. None of the groups or none of the patients that participated had any glycemic issues, nor were they tobacco users. So all 3, they had moderate to advanced periodontitis, and there was one group that was scaling alone, one group was scaling with a placebo, and the other group was scaling with Arestin. The studies primarily looked at the efficacy and long-term efficacy of all 3 groups. So you'll see on the chart here that the 2 gray groups on the bottom were the scaling alone and scaling with placebo. At 1 month mark, so what happened is they did the baseline, did the initial non-surgical therapy, brought them back at 1 month to evaluate, 3 months for a perio maintenance, 6 months for a maintenance, 9 months for the other maintenance, and evaluated it every time. So the gray group on the bottom increased, probing depths decreased by about, 1 millimeter. At 3 months, they had a better improvement in probing depths, greater. At 6 months, only one of the 2 groups actually maintained what they had at 3 months, but at 9 months, both of those groups dipped down back lower than they were at 3 months. So dental hygienists, this is where we see our patients right after non-surgical. We see them at 3-month mark, and we'll say to ourselves, wow, pretty good. They responded well. But then at 6 months, they're dipping back, and then at 9 months, there we are, 5 millimeters bleeding upon probing again. So this is a study that supports the use of that antibiotic, which kills the free-floating bacteria, kills any new bacteria colonizing, helping to gain an attachment to reduce those probing depths and control that inflammatory response. It is completely about controlling that. I've used Arestin since 2001, since it came out, because my husband's was a very advanced periodontal patient. I was able to control his periodontitis from an inflammatory response and destruction, any further destruction to the periodontium for 17 years. My husband should have had surgery, but he didn't choose to because it was extremely expensive. So I had to control him in a periodontal maintenance aspect. And I used that with very frequent recares and using Arestin every time there was bleeding upon probing. Oh, that was a duplicate. Sorry about that. So also looking at periodontal maintenance, thinking about, again, what does maintenance mean? If you were a diabetic, your maintenance would mean control, correct? So if you went to the endocrinologist and your A1C was not under control, would they treat you the exact same way that they treated you when it was under control? No. They would change your medication, maybe look at your diet, maybe add a more frequent recare. So we need to look at, are we really having our maintenance patients under control, or is there a lot of activity of disease, and do we have to do something different? So treat the infected areas differently than you treated them before they were infected, by placing a time-released antibiotic, by using your laser therapy, by changing their home care. Maybe your diabetic patients who have uncontrolled A1C, maybe they need to come in more frequently than 3 months. So looking at that long-term success of treatment based on what you're seeing and what your modifiers are. So I just want to share with you, the next presentation is going to cover barriers to care. We have many different types of barriers. I've identified 3. There's office barriers, personal barriers for the clinician, and I will share with you, I had every single one of them. And then, of course, there are our patient barriers that we see on a daily basis. So I hope you all join us for that, and that'll be our communication presentation. And I'm just going to give you a little story about why I feel communication is so critical to success. There was many years ago, a young woman who was absolutely terrified of dentistry. She was on a fixed budget, had no dental insurance, even though we know dental insurance is not what it should be. But she had not been to the dentist in many, many years, again, because she was terrified. And one day, and filling on tooth number 2, an old amalgam had fallen out. She knew enough because she had been to a dentist many years earlier and had a lot of fillings, root canals, and various other treatments. She believed that if she could keep the area free of food, that she could keep it from hurting. So she kind of self-irrigated to kind of clean that. And then, of course, unfortunately, one day the pain started. Her pain level got so intense that she was taking over-the-counter meds every 2 to 3 hours in order to control that pain. But then again, we know what happens when it starts to abscess. You cannot control that pain. So she decided to grab the yellow pages. Yes, there were yellow pages, it was many years ago, and look for a dentist who did sedation. She found the office, made the appointment, and regrettably, the day that she showed up, the dentist who was certified for sedation was not scheduled that day. So again, office barrier. So when she finally did get to see one of the dentists, because she was so beaten with pain, the dentist convinced her under nitrous oxide to do a pulpotomy. That dentist further convinced her to do a comprehensive exam and follow through with conventional, functional dentistry, because she could see that there were multiple areas in the mouth that were having issues and challenges even without radiographs. It was visible. So the patient took a loan out with Care Credit for $5,000 and proceeded to continue with her functional dentistry. She was so absolutely terrified, but she also knew that she had to come in and take care of this. Then once the dentist was done with all the functional work, she said to her, I'm going to send you to my hygienist. My hygienist is going to clean your mouth. It's going to feel great. And I'll come and check on you when you're at that appointment. So she went to the hygienist. The hygienist proceeded to diagnose her periodontal disease. In Florida, that's a no-no. And she told the patient that she needed $300 and some odd of a deep cleaning. So the patient refused that treatment and said, nope, I will not have that. I just want the cleaning that the dentist wanted me to have. So why do you think that somebody agreed to take out a loan to do something that absolutely terrified them, but refused a $300 and some odd service? And the reason is it was communication, and I'll share with you why. Also, I'll share with you why I know that story. I was that patient. That was me some 25, 26 years ago. I had had dentistry done in Europe as a child, and either I was extremely resistant to anesthetic or they maybe didn't use enough anesthetic, but I used to feel everything. So I will tell you, for me to go to a dentist, it was unbelievably challenging. I was in pain from that tooth number 2, for 10 days. That was better than going until one day I could barely walk. That dentist explained to me that if I didn't help her, well, no, first she explained to me I wanted her to pull my tooth because I didn't need a back tooth. That's what a lot of our patients think. We don't need the back tooth. So she explained to me if she pulls that back tooth, I could have some shifting and moving of other teeth. And she could kind of see that I cared about my aesthetics or my appearance. Then she said to me, Kathy, if we don't take care of some of the other areas that are quite obvious, tooth number 5 had the whole distal had been rotted and broken down. I had started a root canal when I was like 19 and never finished it and never had a crown. And actually, I didn't smile a lot, even in my wedding pictures, because you could see that. So she had said, if I don't take care of some of the other things, you're going to be back here maybe every year asking me to pull more teeth. She goes, you're too young and you obviously care about your appearance. Let me help you stay out of my chair, because I can promise you, I can prevent you from being here. So she took the time to raise the value, let me know that you could do prevention. The dental hygienist came at me way too clinically. First of all, I didn't know the doctor didn't do the diagnosis. Hygienist came at me very, very clinically. She told me I had periodontal disease, which I had no idea what that meant. I thought she was telling me I was dirty and I didn't clean my mouth well enough. I was a smoker back then, not big smoker, just occasional smoker, but I brushed really, really well, but didn't floss, of course, because why did I know why you should floss? So it was interesting that I refused the treatment because I didn't understand what she was saying to me. I didn't understand any of the dental terminology she was using. She was very professional. And again, the doctor didn't diagnose it. So these are barriers that we're faced with every single day. But if that communication is good and that patient understands what is going on and sees the passion that you have, you can be very, very successful in case acceptance of treating periodontitis. So with that, I want to say thank you so much. I do have to apologize that you cannot see me. I don't know what is going on, but my camera's not working. It worked earlier, but it's not working now. So if there are any questions, I would be more than happy to answer any of those.
Kathy, would it be okay if you use the hand features and call on people instead of just talking?
Sure. Would it be possible if you could maybe read some of them? Because I'm not that great at sifting through them, reading and answering at the same time.
Sure. If anybody has any questions or comments, if you want to put them in the chat box, yeah, I can read them aloud and then Kathy can answer. So
excellent.
Dr. Gordon says, great presentation. Thank you.
Oh, thank you so much, Dr. Gordon. I'm glad you appreciate it. There's a lot of questions about my mechanical, my technology skills. There's so many platforms nowadays.
You know, Kathy, what I found most interesting about the presentation when we vetted this with the Hygiene Council was, you know, I too am an older hygienist and quite honestly tried Arestin in the early days and was not as warm on the reattachment promises. What really intrigued me about how Arestin is now being used more to treat chronic and acute localized inflammation and having great success in the treatments of inflammation. So I that's where I really find a great application here. So I'm grateful that the research has expanded. Okay, Kristen from Washington. Hi, Kristen. She says, you've mentioned that laser is only effective for 24 hours. I learned in a previous CE class for LBR that it is effective for 8 to 6 weeks. Can you clarify? That's
Yes.
as a comparison to Arestin.
I definitely can clarify that. But first, Kim, I want to go back to your comments. You know, a lot of times if you have a defect, a vertical defect like my husband had, he had 2 wall defects with 7-8 millimeter probing depths. You will not get attachment gain on those defects. Absolutely not. But if you can control the bleeding upon probing and control that inflammatory response, and that's where I saw the greatest effects with Arestin. I worked for many dentists who use lasers. They actually wanted the Arestin used first before they went in and used the laser. That would have been a secondary approach. So as far as LBR, yes, you are effective at removing more bacterial load at the initial treatment, but it does not stop it from recolonizing that sulcus. Lasers will not, the initial use of an LBR for LBR purposes, it will have effective properties because you removed and you destroyed and you got the calculus out. So that has effective properties, but that bacteria will recolonize. It is not long term. Once that tip is deactivated, what it does is over. So if you could be successful at initial removal, then place an Arestin and you're successful for up to 21 days for recolonization, that's key. I hope that helped.
So Kathy, this is Kim again. How do you think about, you know, the Arestin and laser, you know, kind of living in the same world? So at what point would you say, gosh, I'm going to use a laser instead of placing Arestin, or I would rather go to Arestin as my first tool over a laser? Like, how do you make that differentiation of which one you would apply first? Because I believe there's a space, an application for both adjuncts.
Absolutely, I do. So let's look at disease processes. And I just want all of you to know that I am a huge proponent of laser. I just finished my 18-month battle with the Florida Board of Dentistry, begging them to allow Florida dental hygienists do LBR. So I don't want you to think that I'm not a supporter of lasers. I am, because I understand how well it removes that bacteria at initial therapy. So I am a big supporter of using laser at initial therapy. I am also a big supporter of Arestin. So this is where I would differentiate. So if you have a person that has initial infection, initial disease, you've caught it at the first stage, one area, 5 millimeters, break in the lamina dura, early crestal bone loss. Most of us don't identify or diagnose that disease in that stage. You would be really pretty successful if you got them on a good recare, good home care, and just use your hand and your ultrasonics, because guess what? You would get a millimeter or 2 of reduction, and the patient could take care of that sulcus at home. Now take a patient now that has more moderate, deeper probing depths, maybe a patient who's not going to do great home care. How do you know they're going to do good home care? You're going to probably want to use a little bit more to make sure that you've removed as much of that bacteria as possible. So that's where laser, and then I would always incorporate laser and Arestin. I don't think I would ever go for one or the other. That's why I was begging Florida to allow us to do that, because I love that it reduces the bacteria at initial therapy better than my ultrasonic does. But I would never not use Arestin, because I've seen the great results of the long-term suppression of that inflammatory response. And that is not a label use. They have not been able to test for that. But as a clinician, 20 some odd years I've used it, since 2001. And I can tell you, my husband did not lose 1 millimeter of periodontium in 17 years with those horrible defects. Because, and he had some laser at period times, but for bacterial reduction as well, not by me, but by the dentist. But the Arestin actually helped more long-term for him with that inflammatory response. So I hope that answered the question.
Yeah, Marion has a follow-up question. Marion's in Arizona. Her question is, couldn't you use the laser at, I'm assuming at the SRP, and then place Arestin at a 6-week eval on areas that are still struggling?
Well, of course you could. Of course you could. So let's look at 2 different patients. So say you had a patient who's extremely healthy, horizontal bone loss and early disease. Yes, I'd probably say that that would be great. How about, oh, sorry. Oh, somebody was exiting. How about you take that same patient that now has diabetes out of control? Why would you want to wait 6 weeks? They do not heal well. They have we have to really look at these medical histories instead of just saying all sulcuses should be treated the same or all people. Just like with the AAP wanting to align with oncology, the reason they did that is because a person who has a different stage cancer with other comorbidities is going to have a different cocktail than that person that doesn't. So again, who do you have in your chair and where are they in their disease state and what other modifiers do they have? That's what you would have to look at.
That's great. Thanks, Kathy.
If you have 2 seconds, I can share another story of a diabetic patient and why it's so important to, I hate to say the word hit them with everything, but really, really get their condition under control. I'd had this patient, she was perio maintenance. She came religiously every 3 months. She should have had surgery, but she couldn't afford to do that. I updated her medical history every single time she came in, any new meds, any surgeries, all the good words we're supposed to use and language. No, 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 no. She wasn't responding like she should have. My doctor who used laser also did laser on her as well, and she still didn't respond like she was supposed to. I placed Arestin. She still was having challenges responding. Some days were okay, next time was bad. All of a sudden, she was in for her recare. I'm working tooth number 5. I'll never forget it. She just kept bleeding. I could not control that bleeding. I did the pressure, I did everything. Got up, went to asked her to hold on to the gauze, got the doctor, came in. We ended up placing Viscostat subgingival because we couldn't control the bleeding at that stage. Sat her up, had a discussion. Doctor was asking her medical history questions. And then all of a sudden it hit me. I said to her, when was the last time you had a physical? She said, oh gosh, Kath, it's been at least 15 years. She goes, but I'm healthy. I feel good, so I don't go unless I need to. So doctor and I basically explained to her that there was something going on in her body and that we could not see her again until she went and had a physical because we believe there's something else going on. Well, when she came back on her next recare, she had a sugar level of 360. 360. That patient wouldn't have responded to anything. That's why understanding that patient's medical history, where they are in those modifiers is key. So a diabetic has so many risks of having challenges with their diabetes. That's why they have to check every day. I wouldn't take a chance. I would do everything I could, everything that's at our means to help control that periodontium of that diabetic patient. Once she got her diabetes under control, she still needed Arestin periodically, but she actually looked amazing. It was more like a true maintenance than it was before.
So final question from Sharma. So everybody has a moment to have a bio break before they go back to treating patients. Sharma from Arizona asks, are there any negative side effects to using Arestin? I added the negative because we already know the positive side effects, so I'm just curious. Or any contraindications, I think.
Well, there's definitely contraindications. You would not want to use it on a pregnant woman. You would not want to use it on children, women who are nursing too, because we know the tetracyclines, although it's 1 milligram, depending on how many sites you use. There are side effects that are in the handout, so you'll read that and it'll say in this group, caries was present. No, that just shows that the people that they studied long-term ended up having some other issues. It didn't mean that Arestin caused it. I've used it, like I say, extremely frequently since 2001, and I have never, ever, ever, ever had a negative effect reported from any one of my patients.
Awesome. Well, thanks, Kathy. Thanks, Scott and Mark, for helping us pull this together. And thank you, everybody, for attending and being interested in, bettering our outcomes for our patients. I really appreciate your time. Looking forward to the repeat of this course this coming Friday. And then your area reps will be in your office to do lunch and learns in your office and answer any questions as you move through the hands-on. And then second part of this will kick off mid-November. So any questions for you before we hang up?
Thank you, everyone. Appreciate it.
Thank you, Kathy. Thank you, Kim.
Thank you so much.
Bye, everybody. Have a good day.
Thank you, guys.